Hello everyone and welcome to our module on EKG basics. The EKG is a visual representation of electrical activity as it moves through the heart. So in order to understand EKGs, we need to review how electricity moves through the heart under normal conditions. So normally the SA node located on the right atrial free wall is the pacemaker of the heart, and it depolarizes and sends a wave of depolarization spreading to myocytes in the left atrium and the right atrium. From there, depolarization funnels through the AV node and then goes to the His bundle and then the left and right bundle branches. And finally, it reaches the Purkinje fibers, which are embedded in the myocytes of the left ventricle and right ventricle. And when the Purkinje fibers depolarize, they lead to ventricular depolarization. Shown on the screen is a typical example of electrical activity as it moves through the heart as depicted by the EKG. The EKG picks up electrical activity and plots it versus time. So time is always the x-axis and the y-axis is electrical activity. And anytime there's an electrical event in the heart, it can generate either a positive or negative deflection of the EKG. A positive deflection is upward, a negative deflection is downward. So each of the waves represents some electrical event in the heart. So let's go through what each of them represent right now. The P wave is the first event in the cardiac cycle, and that represents atrial depolarization. The P wave is followed by this flat section of the EKG tracing, and that section is caused because it takes time for electricity to move through the AV node, His bundle, bundle branches, and Purkinje fibers. Once electricity moves through all of these structures, it reaches the ventricles, and when the ventricles depolarize, they generate the largest section on the EKG. That's called the QRS complex, and it represents ventricular depolarization. This complex can include a negative deflection called a Q wave, a positive deflection called an R wave, and another negative deflection called an S wave. Following the QRS complex, there is something called the T wave, which represents repolarization of the ventricle. You do not see a wave showing repolarization of the atria. That's because atrial repolarization occurs at the same time as the QRS complex, and therefore atrial repolarization is embedded within the QRS complex. So here's a normal 12-lead EKG, and it's called a 12-lead EKG because there are 12 different recordings of the electrical activity of the heart. The leads each have a name. Leads 1, 2, and 3 are always shown on the left side of the tracing. Next comes AVR, AVL, and AVF. This is followed by the V leads, V1, 2, and 3, and V4, 5, and V6. Along the bottom of the EKG, there are often one or more so-called rhythm strips. Here, V1 is shown as a rhythm strip and lead 2 as a rhythm strip. On these rhythm strips, multiple QRS complexes are recorded in a row so that you can better determine the heart rhythm. And I've expanded lead 2 at the top of the screen so that you can see that each lead has a P wave, a QRS complex, and a T wave, just like we talked about on the last slide. So most students understand the P waves and the QRS complexes and what they represent. But what's often tricky to understand is what each of the different leads on the surface EKG represent. Notice that the QRS complex in lead 2 is all pointing upward. Notice that the QRS complex in lead AVR is all pointing downward. Notice that in lead V3, the QRS complex is pointing slightly upward and slightly downward. We have to explain this. All of these leads are recording depolarization of the same left ventricle. So why does lead 2 show the QRS complex as upward, lead AVR as downward, and lead V3 as partly upward and partly downward? That's the second key point about EKGs that we have to explain, and that's what we're going to talk about next. So let's go back to this drawing of electrical activity as it moves through the heart. And let's imagine that the left and right ventricles are depolarizing. When that happens, we have electrical activity moving in lots of different directions. Some is moving this way to depolarize the left ventricle. Some is going this way to depolarize the right ventricle. But if we could sum up all those electrical forces, we would get a summation vector that looks like this. Each of the 12 different EKG leads is going to look at this summation vector from a different vantage point. And therefore, each of the 12 leads is going to show the QRS complex, which represents ventricular depolarization, as a different shape because it's looking at the same summation vector of forces from a different vantage point. To make this easier to understand, let's imagine we have a car moving down the street being watched by person 1 and person 2. Person 1 will say that the car is moving away from them. Person 2 will say that the car is moving towards them. They're both correct. They're both watching the same phenomena. It's just that they are observing it from a different vantage point. And that's what each of the 12 leads on the EKG does. It observes electrical depolarization of cardiac structures from a different point of view. Here's another drawing of the heart, and once again I've shown an arrow representing the summation vector of electricity as it moves through cardiac structures. On this drawing I've also shown the vantage point for all of the EKG leads. So let's see if we can make sense of this now. So lead AVR views electrical activity in the heart from the right side of the heart. This means that all electrical activity from the point of view of lead AVR is moving away from the lead. And when electrical activity moves away from a lead, it generates a negative deflection on the surface EKG. Contrast lead AVR with leads 1 and AVL. They view electrical activity from the left side of the heart, so they will see that summation vector of forces moving towards them, and when electrical activity moves towards an EKG lead, it generates an upward deflection on the surface EKG. Leads 2, 3, and AVF view electrical activity from the inferior portion of the heart, and leads V1 through V6 view electrical activity across the heart, with V1 being more towards the right side and V6 being more towards the left side. So now let's look at a normal 12-lead EKG and see if we can make sense of it. Here's lead AVR, and notice that the QRS complex is going entirely downward. That's because lead AVR is positioned on the right side of the heart, and it sees all electrical activity moving away from it. Lead V6, on the other hand, is located on the left side of the heart. It sees all electrical activity moving towards it, therefore the QRS complex is entirely upward. Lead V3 is in the middle, and so it has some of the QRS going upward and some going downward. So all of these leads are looking at the same electrical phenomena. All the QRS complexes represent depolarization of the same ventricle, but they look different because each lead is looking at this phenomena from a different point of view. So here's a summary slide of the key points that we've just discussed. These are very important for you to understand in order to interpret EKGs. Key point number 1 is that the different waves, like the P wave and the QRS complex, represent repolarization and depolarization of structures in the heart. Key point number 2 is that EKGs have 12 leads, and each lead watches the same thing but from a different vantage point. And when the electrical activity moves towards a lead, that generates an upward deflection. When it moves away from a lead, that generates a negative deflection. Let's briefly discuss cardiac pacemakers. As I mentioned earlier, the SA node is the dominant pacemaker of the heart under normal conditions. There are, however, other pacemakers that exist, but they are slower, and therefore the SA node dominates them and controls the depolarization rate of the heart. However, if the SA node fails, one of the other pacemakers can take over. So, as you may know, a normal heart rate is about 60 to 100 beats per minute. That's the rate at which the SA node depolarizes. However, if the SA node were to fail for any reason, the AV node could begin to depolarize the heart, but it can only do so at a rate of about 40 to 60 beats per minute. The His bundle, the bundle branches, and the Purkinje fibers can also potentially become pacemakers. However, they are at even slower rates of about 25 to 40 beats per minute. You should be aware that conduction velocity, in other words, the speed with which electricity moves through the heart, is slowest in the AV node. This is very important physiologically. By slowing conduction through the AV node, the heart has more time for the ventricle to fill with blood, and this helps make the organ a more effective pump. Conduction velocity is fastest in the Purkinje fibers, and the conduction of electrical activity through the atria and ventricular myocytes is in the middle between these two extremes. If we go back to this slide, the reason that the QRS complex does not follow immediately after the P wave is because it takes time for electrical activity to move through the AV node, His bundle, bundle branches, and Purkinje fibers. Most of this time is occupied by conduction moving through the AV node. That's because that's where conduction is slowest. Let's talk about how you can determine heart rate from the surface EKG. You can do this by figuring out how much time passes between two QRS complexes. Remember, each QRS complex represents depolarization of the left ventricle. In other words, it represents a heartbeat. So the time between QRS complexes varies with the heart rate. And if you can figure out that time, you can calculate the heart rate. So the way this is done is by figuring out how many boxes pass between two QRS complexes. And there are two types of boxes. So-called big boxes are represented by the dark lines. I'm marking one big box with my pen here. Between each big box are 5 smaller boxes. So the small boxes represent 40 milliseconds of time, and the big boxes represent 200 milliseconds of time. So if you want, you can count up how many milliseconds pass between two QRS complexes and do the math and calculate the heart rate. However, no one really does it that way. The way it's done is by using a quick method, which involves figuring out how many big boxes pass between two QRS complexes. So to do this, you need to identify a QRS complex that falls on a solid line like this one right here. You then figure out how many big boxes pass before the next QRS complex. You can see that 1 passes, 2, 3, so about 3.5, just a little under 4 big boxes pass before the next QRS complex. Once you know how many big boxes, you can determine the heart rate. If there were just 1 big box between the QRS complexes, the heart rate would be 300. If there were 2, it would be 150. If there were 3, it would be 100. Each additional big box represents a heart rate of 300 divided by the number of big boxes. So in other words, 3 to 5 big boxes between a QRS complex is a normal heart rate, a heart rate between 60 and 100. And that's what we've got here. We've got about 3 to 4 big boxes, which represents a heart rate of somewhere around 75 or so, a normal heart rate. And this is the simple way that everyone does to eyeball the heart rate. You just look at how many big boxes are between the QRS complexes, divide the number 300 by the number of big boxes, and that will estimate the heart rate for you. Next, we're going to talk about something known as the QRS axis, which is something you can determine from the EKG, and it's important in certain disease states. And in order to understand the QRS axis, we have to go back to that summation vector of all the electrical forces moving through the heart that we talked about earlier. If the heart is normal and normally positioned in the chest, then the summation vector of electrical forces moving through the heart looks like this arrow I've shown on the screen here. Those electrical forces move down and towards the left ventricle, just like this arrow on the screen. Now let's suppose we took a grid and laid it directly over the heart and labeled it such that 0 degrees was to the right, positive 90 degrees was to the bottom, plus 180 degrees was to the left, and negative 90 degrees was to the top. If we did this, a normal QRS vector, meaning a QRS vector generated by normal depolarization of the SA node with a heart in the normal orientation inside the chest, would generate an axis that was between minus 30 and positive 90 degrees. In other words, it would usually be in this bottom right-hand quadrant here, or else it could go a little bit up into the top left-hand quadrant, but it would never go beyond negative 30 degrees. And this is what's called a normal QRS axis. This is where the axis is located in patients who have normal hearts depolarizing under normal conditions. It turns out that there are a number of conditions that can shift the QRS axis to the left. This is called a left axis deviation. This happens when the QRS axis is between minus 30 and minus 90. There are a number of things that can do this. Some of them that are worth knowing include a left bundle branch block. This can also occur when you have a ventricular rhythm like ventricular tachycardia. This is a heart rhythm that is not originating in the SA node, but instead is coming from the ventricle itself. There are also some conditions that can cause a right axis deviation. This occurs when the QRS axis is between positive 90 and plus 180. And some of the conditions that can do this include a right bundle branch block, right ventricular hypertrophy, and there are many, many others. With that in mind, let's talk about how you can determine the QRS axis using the surface ECG. In order to do this, we're going to look at specific leads on the ECG and decide whether the QRS is pointing mostly up like this, that's a positive deflection, or mostly downward, which is a negative deflection. And we're going to start by looking at lead 1. Lead 1, when there is a positive or upward deflection, creates a vector of electricity going in this direction towards 0 degrees. When lead 1 is negative, it creates a vector going in this direction away from 0 degrees. The next lead we'll look at is lead AVF. Lead AVF is an inferior lead. When there is a positive deflection in lead AVF, that is a vector of electricity going downwards towards 90 degrees. And when there's a negative deflection in lead AVF, that is a vector going away from 90 degrees. So we can take these two vectors, the vector for lead AVF and the vector for lead 1, and sum them together, and we might get a vector something like this, and that is the QRS axis. And I've cleared away my ink so I can show you that a normal QRS axis would have a summation vector somewhere between negative 30 and plus 90. And because a normal axis includes this area here from 0 to minus 30, many people, instead of using lead AVF, use lead 2. Lead 2, instead of going from plus 90 to minus 90, is actually out here at plus 60 degrees. And so if you use lead V2 together with lead V1, then anytime both of those leads are positive, you will have an axis somewhere in here, which is normal. So that's what many people do. If you've got a positive QRS vector in lead 1, that means you've got a line going in this direction. And if you have a positive QRS vector in lead 2, that means you have a line going in this direction, and therefore their summation is going to be somewhere in this range here, which is normal. Now, in reality, nobody ever calculates an exact number for the QRS axis. Instead, most of us use a quick method to determine whether the axis is normal, leftward deviated, or rightward deviated. So let me go over that quick method now. To use the quick method, you first glance at lead AVR. Lead AVR should always be negative. If lead AVR is upright, it usually means the limb leads are reversed. In other words, it means someone has put the leads on the patient incorrectly. So to use the quick method in actual practice, you start by glancing at AVR to make sure the leads are properly positioned, and if they are, AVR will be negative as shown in this picture on the screen. Once you determine that the leads are placed appropriately, you then look at just two leads on the 12-lead EKG, leads 1 and 2. If they're both positive, like I've shown on the screen here, then the axis is between 0 to 90 and the axis is normal. And most of the EKGs you'll look at have a normal axis, so this is a quick way to rapidly determine that the axis is normal and that you don't need to go any further looking for whether it's a left or right deviation. If they're not both positive, then you have a left or right axis deviation and you need to figure out which one you have. For a left axis deviation, all you need to do is look at lead 2. If lead 2 is negative, it means the axis is between -30 and -90, and therefore you have a left axis deviation. The one exception to this is sometimes lead 2 will look like I've shown here, where it's partly upward and partly downward. This is called a physiologic left axis, which is slightly to the left but still within normal limits. To determine whether you have a right axis deviation, all you need is lead 1. If the QRS complex is negative in lead 1, like I've shown here, then you have a right axis deviation, which is between 90 and 180 degrees. So here's a summary of the quick method, which is what most cardiologists I know use in actual practice. You look at AVR quickly to make sure it's negative, which tells you the leads have been placed properly. You then look at lead 1 and 2. If they're both positive, the axis is normal. If lead 2 is negative, you have left axis deviation, and if lead 1 is negative, you have right axis deviation. And I've shown you the shapes of all these on the screen here so you can remember them. I'll finish this module by going through the different time intervals in the surface EKG, and I'll start with the PR interval. This is the time from the start of the P wave to the start of the QRS complex, and a normal PR interval is 120 milliseconds to 200 milliseconds in duration. And it's very easy to identify PR prolongation with your eye. That's because, remember what I told you before, a big box represents 200 milliseconds in time. So if the PR interval is longer than one big box in duration, then the PR interval is prolonged. And you can develop a prolonged PR interval from first-degree AV block, and I talk about this and other forms of AV block in a separate video. You can also develop a short PR interval if you have a bypass tract caused by the Wolff-Parkinson-White syndrome, and I talk about WPW in its own video as well. Next is the QRS interval. This is the time from the start of the QRS complex to the end of the QRS complex. And a normal QRS interval is less than 120 milliseconds in duration. And I told you before that a small box on the surface EKG represents 40 milliseconds. This means that a normal QRS complex should be less than 3 small boxes in duration. And if we look at this blown up image on the top right side of the screen, you can see that the QRS complex starts and ends before 3 small boxes have passed. Therefore, this is a normal QRS complex. And there are a number of causes of a prolonged QRS complex, but some of the most common are bundle branch blocks. You develop a QRS interval prolongation in a right bundle or left bundle branch block, and in the video on AV and bundle branch blocks, I talk in detail about how to recognize right and left bundle branch blocks. Next is the QT interval. This is the time from the start of the QRS complex to the end of the T wave. The QT interval varies with your heart rate, so in order to determine whether a QT interval is normal, you need to determine the heart rate and then correct the QT interval. This is not something I recommend you worry about doing as a medical student. A rule of thumb you can use, however, is that the T wave should end before you are halfway between 2 QRS complexes. So if we take the space between these 2 QRS complexes and mark the halfway point, you can see that the T wave in this example has finished before that halfway point, and that's what you see in a patient who has a normal QT interval. There are relatively few causes of a short QT interval, but one that you should definitely know is hypercalcemia. On the CCG on the left side of the screen, you can see that the T wave begins almost immediately after the QRS complex. There is no flat portion of the EKG between the QRS and the T wave, and this is what you can see in patients who have an elevated calcium level. There are a number of causes of a prolonged QT interval. These include hypocalcemia. That's easy to remember. It's the opposite of the cause of a short QT syndrome. Also, a number of drugs, especially antiarrhythmics, and also the long QT syndrome, which we'll talk about in a second. To understand why calcium affects the QT interval, let's review the role of calcium in the myocyte action potential. Calcium is responsible for phase 2 of the myocyte action potential. This is called the plateau phase, and in this phase, calcium is moving into myocytes. In the setting of hypocalcemia, there's less driving force to move calcium into myocytes, so it takes longer for calcium to fill the cell. And this phase is going to continue until enough calcium has gotten inside of the myocytes. Therefore, in the setting of hypocalcemia, this plateau phase, phase 2, is drawn out, and it takes longer for myocytes to depolarize and repolarize. And that means that it will take longer for the QT interval to occur, because that phase of the EKG represents the time required for myocytes in the ventricles to depolarize and repolarize. There is a special form of ventricular tachycardia called torsade de pointes. This word means twisting of the points, and it's a form of ventricular arrhythmia that occurs with the QRS complexes getting smaller and then larger and then smaller again. And this is the feared outcome of QT prolongation. If your QT interval becomes prolonged, you will develop torsade de pointes, which results in cardiac arrest and can result in death. And this is why antiarrhythmic drugs which prolong the QT interval are dangerous, because if they prolong it too much, this arrhythmia will develop, and that's how patients can die from taking antiarrhythmic drugs. You can also get Torsades de Pointes from hypokalemia and hypomagnesemia. This is not related to QT prolongation. This is related to effects of these electrolyte abnormalities on ventricular depolarization. Rarely you can get Torsades de Pointes from hypocalcemia. It's interesting. Hypocalcemia prolongs your QT interval. However, it's uncommon for hypocalcemia to lead to Torsades de Pointes. I told you that one of the causes of a prolonged QT interval was something called the long QT syndrome. There is a congenital disorder called the congenital long QT syndrome that is caused by abnormal potassium and sodium channels in the heart. This is a very rare disorder, but the reason they may ask you about it on the USMLE Step 1 exam is because it's a way to test your underlying knowledge of the basic myocyte action potential. Shown in blue on the screen here is a normal cardiac myocyte action potential. Shown in red is what the action potential can look like when either the sodium channels or the potassium channels are abnormal. Sodium channels are responsible for this phase of the action potential. Potassium channels are responsible for this phase. If either the sodium or potassium channels are abnormal, the myocyte action potential can get drawn out, as I've shown in this red example on the screen. When it takes longer for myocytes to depolarize and repolarize, that results in a prolonged QT interval on the surface EKG, and that's what happens to children born with the congenital long QT syndrome caused by abnormal potassium or sodium channels. The way this may be presented in a board question is as a patient with a family history of sudden death. The reason there is a family history of sudden death is because the congenital long QT syndrome runs in the family and other family members have died of Torsades de Pointes caused by a prolonged QT interval. A classic scenario is a young patient who has recurrent seizures. The patient is not really having seizures. They're actually passing out from Torsades de Pointes, and the EKG will show a long QT interval. There is also a variant of the congenital long QT syndrome that has been well described called the Jervell and Lang-Nielsen syndrome. This occurs in Norway and Sweden. It results in the long QT syndrome in association with congenital deafness. It's very rare, but they sometimes ask you about this on board exams. Much more common than the congenital long QT syndrome is the acquired long QT syndrome. This is where a patient has a normal QT interval on their EKG, but acquires a prolonged QT interval because of a drug they are taking. This is commonly caused by a number of antiarrhythmic drugs, which I discuss in another video. It's also commonly caused by levofloxacin, which is a fluoroquinolone antibiotic. It can also be caused by Haldol, which is an antipsychotic, and it can be caused by many, many other drugs. And importantly, for families and family members who have the congenital long QT syndrome, they need to avoid all these drugs. If their QT is prolonged at baseline from the long QT syndrome and then they take one of these drugs, it can be potentially fatal. Let me mention peaked T waves. These are T waves that are unusually tall, like these I've shown on the screen here. This is classically seen in hyperkalemia. It can also occur very early on when patients develop ischemia. These are called hyperacute T waves, and they often precede ST segment elevation in acute ischemia. Lastly, I'll mention U waves. This is a deflection that comes after the T wave, hence the name U wave. It's usually an upward deflection, just like the T wave. The origin of U waves is not clear. One of the prevailing theories is that it might represent repolarization of the Purkinje fibers, although there are other theories. U waves can be seen on a normal EKG, but the classic situation in which prominent U waves are seen is in the setting of hypokalemia. And that concludes our module on EKG basics.